presentation of a patient with severe ARDS who was a case of pancreatitis and was not able to maintain oxygenation with oxygen. So subsequently, we tried to use ECMO for that patient and with good results. So Dr. Prashant and Dr. Priyanka will be अच्छा पहले आप sorry you are Tavish. Dr. Tavish will present the gastroenterology gastroenterology details.
Very good afternoon, everyone. I will be presenting initial clinical history of the patient when the patient was admitted. So we had a patient, 50-year-old female with no prior comorbidities, who presented with complaints of typical pancreatic type of pain associated with nausea and vomiting on 18th of September 2023. Initially, she was evaluated at a local hospital, and where her amylase and lipase was significantly elevated, and X-ray abdomen was also done. There was no features suggestive of obstruction and perforation, and ultrasound abdomen was suggestive of bulky pancreas with peripancreatic collection. So she was diagnosed, and there was a past history of recurrent biliary colic, and ultrasound also showed multiple gallbladder calculi. So she was managed in lines of acute biliary pancreatitis with conservative management. But despite this conservative management, her clinical condition worsened, and she presented to AIIMS emergency on day 7 of her illness with persistent pain abdomen, progressive worsening of breathing difficulty, and decreased urine output. On presentation, her vitals is she had a heart rate of 116 and she had hypoxemia. So she was evaluated in emergency and urgently shifted to gastro ICU on the same day of admission. So at presentation to gastro ICU, her SUS parameter was 4/4. She had tachycardia, TLC was elevated, and she had fever, and respiratory rate was more than 22. Her PF ratio on ABG was 80. She had type 1 respiratory failure. Intra-abdominal pressures was significantly elevated, that is 23 mm of Hg. On point of care ultrasound was done, which IVC could not be properly visualized because of inflammation and bowel gases. On lung scan, there was bilateral basal profiles. There was no consolidation, and there was moderate ascites. On further evaluation, our hemoglobin was 5.1 counts. At day 2 counts were 5,000, and platelet count was 28,000, and creatinine was elevated, and there was hepatic dysfunction also. On as hemoglobin was low and there was thrombocytopenia and renal dysfunction, we kept a possibility of thrombotic microangiopathy, which is a known complication of acute pancreatitis. So we ordered a cystocytes. Cystocytes were peripheral smear cystocytes was 3.5, and there was evidence of hemolysis. LDH was elevated and retic count was also elevated. So we kept a possibility of acute pancreatitis associated thrombotic microangiopathy, and we calculated a plasmic score, which was high risk for TTP or TMA. So we kept this possibility. She had liver dysfunction also. There was a suspicion of cholangitis. So although on ultrasound her biliary radicals were not dilated and we could not find any stone in the distal CBD, we started her on IV antibiotics in view of suspicion of cholangitis, and subsequently her LFT improved. So after in our gastro ICU, the initial working diagnosis was severe acute pancreatitis. She came to us with on day 7 of illness. Etiology was biliary. She had gallstone and there was deranged LFT. In systemic organ failure, she had acute lung injury, grade 2, and acute kidney injury and thrombotic microangiopathy, likely pancreatitis related. On local complications, she had ascites and abdominal compartment syndrome. Intra-abdominal pressure was 23 on presentation, and there was mild bilateral pleural effusion, which was non-drainable, and she had SUS parameters. So she was managed in lines of severe acute pancreatitis. IV fluids initially were restricted because there was bilateral B profile. So we gave her maintenance fluids according to lung scan guided and IVC guided. And analgesia was given with opioids and paracetamol, and rescue analgesia was given with fentanyl. Organ support for acute lung injury, we initially kept her on HFNC, and subsequently as her respiratory distress was worsening, she kept on NIV. And for yes, so this was for organ support. She had a respiratory failure for which we kept her on high flow nasal cannula, and on which she was not, her respiratory distress was worsening, so we kept her on non-invasive ventilation. For local complications, she had abdominal compartment syndrome and ascites, for which we kept the patient nil per oral, and nasojejunal tube was kept on drain, and ascitic percutaneous drain was inserted. We drained around 2.5 liter of clear fluid, after which her intra-abdominal pressure decreased from 23 to around 14. She was started on antibiotics. Generally, in 1 to 2 first and second week, we generally don't give antibiotics to patients for acute pancreatitis, because we have a suspicion of cholangitis also. So in the second week itself, we started her on antibiotics also. For suspicion of, we had a high suspicion of TMA, thrombotic microangiopathy, pancreatitis associated. So we consulted with hematology, and we have given her a session of plasma exchange, PLEX. After plasma exchange, her hemoglobin is stabilized, her platelet count improved to more than 1 lakh, and her cysto size decreased from 3.5% to less than 1%. But in third week of illness, patient continued to deteriorate, mainly because of respiratory failure. She was having progressively increasing respiratory distress, and P by F ratio was 120, which was decreasing. And on chest X-ray, there was increasing infiltrate. On lung ultrasound, there was bilateral diffuse B profile and bilateral basal dense consolidation. She was intubated in view of type 1 respiratory failure, and post intubation, the tracheal aspirate culture grew Acinetobacter baumannii. She was diagnosed to have severe ARDS with likely hospital acquired or ventilator associated pneumonia. So in view of, even despite maximal ventilatory support, her PF ratio was not improving. She continued to be hypoxemic, and PF ratio decreased to around 100. So in third week, patient was having a persistent organ dysfunction. So we ordered a CT, CECT chest and CECT abdomen. And patient was shifted to AV8 ICU for further management of severe ARDS. So now I would like to invite my colleague, Dr. Surbi from radiology. Shivani.
Good afternoon, everyone. I'll be covering the radiological aspect of the patient. I'll begin from the initial radiographs. In this, we can see there's mild blunting of the bilateral CP angles, which has increased in the radiograph dated 1st of October. This suggests bilateral pleural effusion. Lung parenchyma were cleared at this time point. Now, coming on to the CECT chest and abdomen sections, which was done on 3rd of October. In the abdominal sections, we can see there is gross ascites. Along with that, there is a hypodense lesion in the spleen. This could represent just a small splenic granuloma. In the gallbladder, there are subtle hyperdensities seen. These are representative of cholelithiasis. The pancreas appears diffusely bulky with significant peripancreatic fluid collection and the stranding. Even in the bilateral perirenal spaces, there are fluid collections along the thickening of the anterior posterior renal fascia. These all are suggestive of acute interstitial pancreatitis. Now coming on to the lung windows, in the mediastinal window we can clearly see that there are bilateral pleural effusion. In the lung window there was a patchy of consolidation in the right middle lobe and in the right lower lobe, and there was a smooth interlobular septal thickening noted in the right apices. So since there was no pancreatic or peripancreatic necrosis, we gave modified CT severity index as 6. In the further radiograph dated 5th of October, we can see there is increased opacity in the left lung and in the right lower zone. This could be due to the layering of the pleural fluid as the X-ray was taken in the supine position. In the further subsequent radiographs, there are areas of bilateral perihilar consolidation, which are subsequently increasing on the serial radiograph. And there are no area of development of bilateral upper zone consolidation also, as can be depicted here and in this bilateral perihilar region. In just the pre-ECMO X-ray, we can see there are diffuse infiltrates in the bilateral lungs, and these increased area of opacities are also seen. This could represent consolidation. These are just post-ECMO X-ray. In the abdominal section, there is a cannula. There is a draining cannula seen in the right paraspinal region. This is likely in the IVC, whereas the returning cannula is seen in situ with the tip in right atrium. There are area of bilateral upper zone consolidation. In the further subsequent radiographs, we can clearly see that those perihilar and upper zone consolidation consolidation are slowly decreasing. Now the further presentation will be taken by Dr. Prashant.
So this patient shifted to us from AB to ICU in third week of pancreatitis when she had a ARDS, which was worsened by query hospital-acquired pneumonia, since patient had a culture positive with Acinetobacter baumannii. So when she shifted to us, she was in severe ARDS with PF ratio of 70 and acute kidney injury. We had given her 2 proning sessions of 20 hours each, but she was not responding, and her PF ratio was persistently less than 100 only. So we calculated the Murray score, which is designated for the severity, and we can, according to the ELSO guideline, we can determine whether the patient had required ECMO support or not. Here we found almost out of 4, 3 quadrants of X-ray were involved. Her PEEP requirement was persistently between 12 to 14. Her PF ratio was persistently less than 100 despite 2 proning sessions, and her compliance was less than 20. So her average Murray score was 3.5. So we plan to initiate venous ECMO in view of persistent refractory failure due to ARDS, which is not responding to the conventional therapy. So for the ECMO preparation, first we take a written informed consent after explaining everything about vascular injury, complications due to anticoagulation, and the risk of thromboembolism. Then we prepare the circuit, and priming of the circuit done with the normal saline, and calibration of the flow and bubble sensors on the ECMO machine was done. For the vascular access, we did a UHG, and we checked the vascular anatomy. Then cannulation was done using both the ultrasound, TT and TE guidance, thoracic and transesophageal guidance. So for the drainage, we had put in right femoral vein 25 French cannula, and for the return cannula, which was placed in right internal jugular vein, which was of 19 French. Then this vascular access, after putting the vascular access, here we can see a drain cannula in a right femoral vein, and here is the return cannula, which is seen in right internal jugular vein. So for the confirmation, as we discussed earlier, we did an X-ray. Here in X-ray, we can see the drain cannula, which is present in the IBC, and here is the return cannula, which is seen in the RA, right atrium. So it was also confirmed by the ultrasound. Here we see in right atrium there is a return cannula, and from left side we can see a drainage cannula. So the distance between 2 cannula tip was 7.5 centimeter around, which was found to be adequate, and there was no recirculation of the blood flow. So after establishing the ECMO circuits, we gave a heparin bolus of 5,000 units followed by infusion, and we managed the anticoagulation with the help of point of care ACT, which kept of target 180 to 220 seconds. Initial ECMO settings were kept with a blood flow 4 liter or achieved with RPO of 3000 per minute. Sweep gas flow for the CO2 washout was kept at 4 liter per minute. FDO2 on the ECMO machine was kept 100%. And initial ventilator setting we kept under a control mode of PCV, and with average tidal volume of 140 to 160. And we kept her on inverse ratio ventilation for better improving the oxygenation of alveoli. During the ECMO, after putting on a day 1 only, patient had a new onset of hypotension and requirement of dual vasopressors. So we ruled out all the possible causes like hypovolemia or LV dysfunction, but we found that her volume status was normal and her heart contractility was normal. However, her systemic vascular resistance index was found to be low, so it was suspected of distributive kind of shock. So it is attributed to usually ECMO circuit associated inflammatory response or vasoplesic syndrome. When the blood comes in the contact with the artificial circuits, there tend to be release of some inflammatory mediators in initial few hours. So for that distributive shock component, we gave a trial of methylene blue. Patient found to be responsive, and we continued methylene blue infusion for 12 hours. And the vasopressors were subsequently tapered off in next 24 hours. So after achieving the hemodynamic instability, the decision of percutaneous dilatation and tracheostomy was taken. Anticoagulation we continued. Neck anatomy was checked by doing ultrasound, and it is done using single-step dilatation technique, and there was no bleeding during the procedure. Post tracheostomy, we discontinued the muscle paralysis, and the sedation requirement also came down. monitoring. This patient totally was on ECMO support for 6 days. During this time, we did monitoring of clinical examination with the help of GCS, pupillary examination, chest X-ray, serial ABGs, APTT, and point of care ultrasonography. And ECMO parameters were also checked. So here we can say this patient was totally on ECMO for 6 days. Initial first 2 days we kept in on a control mode, and we managed. Then followed by on the day 2 when we did a tracheostomy, patient was paralysis was discontinued. The patient was taken on APRV mode, and the sweep gas flow was subsequently tapered off with the help of PCO2. As the PCO2 was coming down, so the requirement of sweep gas flow also came down. Initially on APRV, patient kept up to day 4. When on the APRV, the pressure requirement came down, we shifted her to PSV mode, and subsequently we tapered off her sweep gas flow, and she was able to maintain a PCO2 36.3 on day 0 with 0 sweep gas flow. Here, as we discussed earlier, this X-rays, here on the most left side, we can see the prior to the ECMO. Here we can see bilateral basal consolidation and bilateral diffuse infiltrate, which is suggestive of ARDS picture, because we had ruled out all the other possible etiologies of bilateral diffuse infiltrates. On day 3 of ECMO, we can see a clearing of the X-ray, and on day 5 ECMO, when patient was ready for weaning, we can see the sufficient clearing of the bilateral infiltrates with improvement of clinical parameters and improvement of the ventilatory status also. So in the other supportive management during this ECMO duration, we found out patient was having blood culture which came positive for Candida albicans. So according to the sensitivity pattern, caspofungin was added. In the ETS period, carbapenem resistant Acinetobacter pavoni was present. So we gave antibiotics appropriately like polymyxin B and minocycline. Steroids were given as per ARDS protocol. Then enteral feeding were continued from day 1 of ECMO only with the help of prokinetic support. And we did a regular intra-abdominal pressure monitoring also, as it was previously elevated. So after putting patient on ECMO, we found that patient also had simultaneous evidence of fluid overload also. So we did fluid deresuscitation with the help of IVC, lung ultrasonography, and anti-pro-BNP. So patient was given albumin furosemide infusion, and we did an anti-pro-BNP on day 0. It was 3,500, and after we made her cumulatively negative over 3 days, 6 liters of negative balance. Her anti-pro-BNP had significantly come down with improvement of clinical parameters, X-ray, and ECMO parameters. So here we can see after the patient had achieved a clinical stability, then we started initial on APRV mode. Initially the P high, the pressures were kept high, but subsequently up to day 4, we kept drop the pressure. This is called a drop and stretch technique. When the patient's compliance improves, the pressure requirement comes down, the alveoli oxygenation improves. So after coming pressure APRV mode, P high requirement came less than 15. We switched her on to PSV mode, and gradual weaning was started. On the day 5, 6, subsequently she was ready for wean from the ECMO. Here on the bottom, we can see the initial sweep gas flow requirement from 3 liter. It has come down to 0. So she was that shows that patient was able to wash out by lungs because her native pulmonary functions had improved. So after achieving weaning, we switched the sweep gas flow and observed for 6 hours. On the ABG, we see acceptable PO2 and PCO2 parameters. Anticoagulation stop for 1 hour. Then we removed both the cannula simultaneously, and local pressure were applied for almost half an hour and followed by local dressing. And we monitored this local site for next 24 hours bleeding. There was no any bleeding found. Post ECMO, all the supportive care were given with utmost emphasis was given on the physical rehabilitation with the help of mobilization, chest physiotherapy, and incentive spirometry, and enteral nutrition was given. Then after that, we also did a gradual weaning from mechanical ventilation. Initially, she was on PSV mode, followed by she was kept on room air, and she be observed for 24 hours. She was able to maintain on room air. So after she was able to maintain on room air, we did a decannulation of tracheostomy on day 7 of post ECMO. And patient shifted to ward. We took a regular follow-up, and patient was discharged from the ward after 2 weeks of ward stay. So I would now request Dr. Priyankar, our faculty, to take over further.
So this was the day when we were shifting the patient to the ward, and you can see the tracheostomy has been removed. She does not have any more lines, and she was feeling better. Okay, so just to sum up our case, this was a case of severe acute pancreatitis who subsequently developed severe ARDS and then was rescued using ECMO strategy. So mortality in acute pancreatitis, the reported mortality with severe acute pancreatitis is about 15 to 40%, and the early mortality is due to extrapancreatic organ failure. This includes respiratory failure, renal failure, and cardiovascular failure. Late mortality in pancreatitis is because of necrosis and infectious complications. ARDS in acute pancreatitis, it is one of the main extrapancreatic organ failures, and it is usually secondary or extrapulmonary ARDS. It is because of the hyperinflammatory state, and there is proposed mechanism of circulating trypsin and phospholipase A2 in causing the ARDS. Although in this case, it was probably also a component of hospital-acquired pneumonia that contributed to the ARDS. 1/3 of all deaths from acute pancreatitis are directly caused by ARDS, and about 50% of deaths in acute pancreatitis occur within the first week, and of them about 50% are due to ARDS. So ARDS is really a big problem in acute pancreatitis. What are the special problems of ARDS with severe acute pancreatitis? In pancreatitis, it is a hyperinflammatory state, and there is extensive fluid creep from the leaky capillaries. This fluid creep causes severely reduced chest wall compliance. This is also worsened by pleural effusions, gut edema, ascites, and abdominal collections. So all these make ventilation very difficult. This needs high ventilator driving pressures, and this causes high afterload of the right ventricle, and this causes hemodynamic instability. So all our attempts to dry up the patient, they kind of fail, because whenever we try to dry up the patient, they go into hypotension. Also, this high RV afterload, this causes venous congestion and worsens the abdominal compartment syndrome in these patients. And of course, this is a hyperinflammatory type of ARDS, so there is high chance of early progression to the fibrotic stage. So how ECMO helped our patient? It reduced the ventilator dependence, so there was less chance of ventilator-induced lung injury. It helped in effective right ventricular unloading, so this improved hemodynamics. This in turn helped us resuscitate the patient nicely, and we could dry up the patient, and we also reduce the requirements of sedation and muscle paralysis, so there was less ICU acquired weakness, and so patient had good muscle power at the end of the ICU stay. So because of this strategy, we could go from the X-ray on the left that was just before ECMO to a relatively nice X-ray on the right, which was after 5 days, which is very rarely seen with otherwise conventional management. So when should we go for ECMO? So this is data from one of the largest ECMO referral hospitals in Germany, and this shows that if you start ECMO within 5 days of invasive mechanical ventilation, the odds ratio of mortality is 0.33 compared to starting later. So starting within 5 days has a 3 times more survival than if you initiate ECMO later. And regarding use of ECMO in patients with severe acute pancreatitis, the survival rate in these patients is about 60%, which is more than the normal reported survival rate with ECMO, which is around 40 to 50%. So patients with pancreatitis who go into ARDS, they do really well with ECMO. So when should we consider ECMO in ARDS? So it should be severe ARDS. It should be early in the disease, because going for it late in the disease may not really help. And these patients usually respond poorly to prone positioning. And we can calculate the Murray lung injury score. If the score is more than 3, we should definitely consider ECMO. So take home message, it is never too early for ECMO. And ECMO allows aggressive fluid removal, and this leads to dry lungs and faster recovery. Thank you.
Compliment the entire anesthesia team for taking wonderful care of this section. But not only this, whenever we are doing a situation like this, particularly what interaction and this situation has been known for a while. With regard to this particular patient, the timing was pretty good. Whenever you have such patients, in the first week or 2 weeks, they have the worst how to define she treated the lungs. And because she could be restricted to only top 100,000, she was almost so bad. The issue comes in cost and the cost and also. Because for us, whenever you have patient with organ failure, anybody with organ failure will not forget out. What we call persistent organ failure. And these are, it is not only the cost, it is availability of those circuits at time and the consent from the verifier. Because maybe our experience is very limited and obviously the mobility and mobility is likely to be high and the relatives may not agree that first of all they have to shell out X amount of money and the outcome is again not likely to be very great. Or we cannot predict how. So that is one of the factors. Any comments by? Circuit is costing 20,000 per day. It's 80,000.
The circuit was about the circuit. And cannula, total 40,000. But it is a one-time thing. These circuits usually last, they last for almost 2 to 3 weeks. So by the time usually patients they recover or
The company makes the circuit like a package because it's a Finland and price is 2.25 times and one camera, electric camera, photo camera, which are around 40 to 50,000. So this is a very because they are using that. You can we buy from the art department, but that is also in the limited number, so we have to see that. Otherwise, initially to begin with, one time, production cost is not. No, it is not. Yes, it's a one time. One time. Because the patient is generally very sick, outcome is not likely to be good. So relatives may not agree. 2 lakh rupees is not responsible. Very difficult. I would prefer that also not to be most of the patients that we have in the what percentage of the normal oxygenation can be provided by maximum? So suppose how much is it adding to that? So we can provide about 80% of oxygenation. So, but still native lungs need to do about 20% of the work. That's the initial part. Yes. Usually in ARDS 45, the oxygenation is not the main problem. Main problem is carbon dioxide removal. Because to remove the carbon dioxide, we have to give a lot of destructive ventilation, and that is what causes the main problem. So ECMO can achieve 100% of carbon dioxide removal. This sweet gas flow. Sweet gas flow is, the blood is going through a extracorporeal membrane. So just like in dialysis, so the blood is going and dialyzer is going against it. So the dialyzer takes away all the waste. So in this way, the blood is going through a membrane and gas is going against it. What is that? That is, we usually give 100% oxygen, and depending on how what rate we give the sweet gas, we can achieve more carbon dioxide removal. So if we want more removal, we increase the rate. If we want less removal, we reduce the rate. And weaning is done by gradually reducing the sweet gas rate. As we gradually reduce it, and we see that the lung can maintain carbon dioxide clearance, we know that the native function is gradually